Hello students, let us begin today's class on discussion on diabetes mellitus. We shall be focusing on comparison of type 1 diabetes mellitus versus type 2, and we shall see further topics regarding the same, beginning with what is the age of onset of type 1 diabetes mellitus. It's usually young children, while type 2 it is adult onset. What about HLA association? It is associated with DR3 and DR4. And in type 2, there is no HLA association. The etiology in type 1 is autoimmune, while type 2, there is insulin resistance, which later leads to impaired insulin secretion. The body weight, usually in type 1, it is normal to underweight, while they are obese in type 2. The presentation is abrupt in onset in type 1, whether on the other hand, it is gradual or symptomatic in type 2. Family history may or may not be positive in type 1, but it is usually strongly positive in type 2. What about the serum insulin levels or the C-peptide levels? This is an MCQ for you. So, students, please note down, it is low in type 1, while it is high in type 2. And regarding the insulin requirement, type 1 has an absolute requirement, while type 2, initially we start the patient on treatment with oral hypoglycemics such as metformin, sulfonylureas. Gradually, the requirement for insulin can develop. Alright. So, how about the clinical features? Dear students, you should know that the presentation of type 1 DM can directly be with a DKA. So the child or the young, adolescent might not even know that he has a pre-existing diabetes mellitus history. So the presentation itself could be a diabetic ketoacidosis. And this is absolutely common in type 1 when compared to type 2. It is also associated with other autoimmune diseases such as thyroid disorders and Addison's disease, your rheumatoid arthritis, your Schmidt syndrome, which is nothing but your polyglandular failure syndrome. On the other hand, type 2 DM has something known as a non-ketotic hyperosmolar coma. I think all of you are aware of a term known as HHS, hyperglycemic hyperosmolar state, which can also lead to coma. So this is more common in type 2. So type 1 has DKA and the counterpart is HHS in type 2. So like we discussed, type 2 DM individuals are usually obese, in their old age, insulin resistant, might present with HHS, family history of diabetes mellitus, metabolic syndrome, and what are we missing here is your C-peptide and insulin levels are extremely high. On the other hand, type 1 DM, the individual is thin, young, insulin deficient, and might present with DKA. And what happens to the insulin and C-peptide levels? They are usually low. So please remember this diagram where the patient is thin, cachexic in type 1, obese, middle-aged in type 2. So going further with our comparisons, let us now compare two very important ones, that is type 2 DM versus maturity onset diabetes in the young, okay, MODY. So type 2 DM is usually predominantly in middle to old age, while as the name suggests, this MODY is predominantly in the young, less than 25 years. So what is the pathology? In type 2 DM, there is beta cell dysfunction causing insulin resistance. In MODY, there is only beta cell dysfunction. There is no insulin resistance. Okay. So there are two factors here, but there is only one factor here. Family history is positive in both scenarios. The inheritance is polygenic in type 2, while the inheritance is monogenic or autosomal dominant. So this is your next MCQ that I want you to concentrate on. They might ask you what is the inheritance pattern of MODY, or they might give you a clinical scenario where a young patient is presenting with diabetes, and this diabetes has been there in the family and it is autosomal dominant. So please remember that time that you might get confused between type 1 and you might get confused whether this is MODY. So these are the subtle clues that you have to look for. What about vertical transmission? Like I just said, successive generation vertical transmission is not essential for diagnosis in type 2. So the parents might not have type 2 DM, but because of the lifestyle, because of the obesity, the child might develop in future when he turns 40s or 50s, he might develop type 2 DM. What about MODY? In MODY, the vertical transmission through at least 2 successive generations is essential for diagnosis. So he means at least 2. So ideally 3 is required. Alright. So what about insulin dependence? Both type 2 and MODY are non-insulin dependent. So the treatment can be begun with oral hypoglycemic agents. Obesity is common in type 2 while uncommon in maturity onset diabetes in the young. Decay is uncommon in both. The serum insulin levels again is high in type 2 while it is low in MODY. Okay. So the final discussion for today's topic is going to be what are the different genes that have been asked multiple times in your NEET or your next exam is going to be your MODY type 3, which is the most common. This is HNF1 alpha, that is hepatic nuclear factor 1 alpha. I want you to remember this. MODY type 1 has hepatic nuclear factor 4 alpha. So HNF-FA 4A and MODY 3 is HNF1 alpha. This is what is frequently asked, HNF1 alpha, while MODY 2 has glucokinase. Okay, so GCK is what gene mutation is there. All right. So also what has been previously asked is which MODY is associated with renal or genitourinary abnormalities. So you can see here MODY type 5 is associated with renal or genitourinary malformations. Alright. So dear students, this was a short discussion on type 1 versus type 2 DM and type 2 DM versus maturity onset diabetes in the young. I hope this was useful for your exam.